The inguinal region is a really fascinating bit of anatomy, and one that confuses a lot of people, so I wanted to present it from perhaps a slightly different perspective. This is the pelvis, the classic front view. But today, I want you to imagine that you go inside of the abdominal cavity and you're looking downwards and forwards towards its right side. This is what it would look like. You've got the iliac crest coming forward to the ASIS. You can palpate those on yourself. That's the pubic tubercle down there. The smaller bump in the middle is the AIIS, anterior inferior iliac spine. Pubic symphysis would be here, and there's that big hole, the obturator foramen. And don't forget, we're just focusing on one side for today, but the mirror image is also happening on the left. Alright, now let's add in some stuff. Spanning from the pubic tubercle up to the ASIS, we have the inguinal ligament. Now, there's a couple of important structures that travel under the inguinal ligament to get from the abdominal cavity into the leg. First, these two muscles, the iliopsoas and the pectineus. As you can see, the iliopsoas goes under the inguinal ligament, more on its lateral side, and the pectineus also goes under, but medially. So that's where they go on our diagram. We still got this bit of empty space left, so what goes through that? The answer is a vein, artery, and nerve, in that order from medial to lateral. Specifically, this is the femoral nerve, and that's the external iliac artery and vein, as it becomes the femoral artery and vein. Remembering, external iliac becomes femoral when it crosses the inguinal ligament. Like I said, you can use van to remember the order they come in. Or the other one you might have heard is navel. Obviously, that goes in the other direction, from lateral to medial. But in many ways, I actually like that one a bit better, because the E and L also stand for something useful, which we'll talk about momentarily. There's a ligament called the pectineal ligament of Cooper, which runs along that superior pubic ramus where the pectineus is attached, and then arches up over the iliopsoas as the iliopectineal arch. That's the front view for your reference. Pectineal ligament, iliopectineal arch. And finally, this angle between the inguinal ligament and the pectineal ligament is sort of webbed over, and we call that the lacunar ligament. I love the lacunar ligament. It's one of those things that feels so pointless, but also so obvious, you know what I mean? Anyway, you'll notice this leaves us with a tiny empty space, which we call the femoral ring. And the reason why this empty space exists is to allow the femoral vein next to it to expand and contract to accommodate changes in blood volume. And that's what the E and L in navel stands for. E stands for empty space, which is the femoral ring, and L stands for the lacunar ligament and some lymphatics. And if contents of the abdominal cavity, such as fat and then bowel, protrude out into the femoral ring, that is called a femoral hernia. And obviously a predisposing factor to that is if you have a naturally wide femoral ring. Now, so far, we've just been sitting in the abdominal cavity staring down at the pelvis, but of course, stretching up in front of us, we have the entire abdominal wall. So let's draw that in, and there's the rectus abdominis. And to supply the abdominal wall, the external iliac artery gives off a branch right before it crosses the inguinal ligament called the inferior epigastric artery, which courses up the abdominal wall. And this creates a little triangle, as you can see, between the inguinal ligament, the lateral border of the rectus, and those inferior epigastric vessels, called Hesselbach's triangle. And if fat or bowel protrudes through this natural weak point, that's called a direct inguinal hernia because it goes directly through the abdominal wall at Hesselbach's triangle. A predisposing factor to that, therefore, would be a weakening of the transversalis fascia, which you may remember is one of the layers reinforcing the abdominal wall. Let's actually draw in some of these layers. We're sitting in the abdominal cavity, right? So the first layer you see is the parietal peritoneum. If you lift that off, you'll see the transversalis fascia, and then if you lift that off, you'll see the muscles, the transversus abdominis. Now, you notice I've drawn in this tube in black here. That is the inguinal canal. It's a tube that goes from the abdominal cavity into the testicles in men, or the labia in women. The site of its entrance at the abdominal cavity is called the deep inguinal ring, and the site where it pierces and exits the abdominal wall is called the superficial inguinal ring. Now, I'm just going to separate the layers of these side muscles real quick. What I want to illustrate here is that the inguinal canal sits with the external oblique in front of it, forming its front wall, whereas the internal obliques and the transversus abdominis, you'll see I've cut that little divot into them, and that's because they sit above the inguinal canal, forming its roof. Then the transversalis fascia forms its back wall, if I just lay that back down, and of course the inguinal ligament forms its floor. Alright, now let's put a little opening in the transversalis fascia at the deep inguinal ring to allow some things to go in and out of the canal. In men, there's the vas deferens carrying sperm from the testis. It heads towards the midline to join with the urethra and go out the penis, which of course is a midline structure. There's also the testicular artery, which you remember from Rupert block branches directly from the aorta to go supply the testis. If abdominal contents like fat or bowel bulge into here, through the deep inguinal ring into the inguinal canal, that's what we call an indirect inguinal hernia. Now, remember in embryology, the testis actually originates really high up in the abdominal cavity, and they get dragged down through the inguinal canal to end up in the scrotum. As it does so, it pulls the parietal peritoneum with it, forming the processus vaginalis, which should eventually cleave off. That way, the abdominal cavity should be separate from the layers around the testis, but there is a small proportion of people where it doesn't properly cleave off. They're left with a patent processus vaginalis, so they'd have an opening in the parietal peritoneum as well, which connects all the way into the scrotum. And that, as you can imagine, would be a predisposing factor to an indirect hernia. Finally, let's wrap things up and simplify our diagram. That's the inguinal ligament, inferior epigastric vessels, vas deferens, and testicular vessels. Indirect hernias go through here, direct hernias go there, femoral hernias go there. This space contains the giant external iliac vessels going into the leg. So surgeons call this the triangle of doom, because if you mess around in this space and put a hole in one of those vessels, the person could very quickly exsanguinate. It would not be good. And finally, this is the triangle of pain, because the femoral nerve goes there, and as you can imagine, if we poke that could cause chronic pain. And there we have it, the 5 surgical triangles for an inguinal hernia repair. And that's what it looks like on an actual laparoscopic procedure. That's partly why I decided to present it from the inside looking forwards. Thank you everyone for listening. I hope that explanation was helpful. It's certainly a complex bit of anatomy, but I think a really rewarding one to understand as well. A special thanks to Drs. Shaun Purcell, Anna Isaacs, and Candice Silverman. I learnt this from them.